All right, continuing the advanced EMT. Again, we're using the advanced EMT, a clinical reasoning approach, uh, published by the Pearson Publishing Company. It's Melissa Alexander and Richard Bell were the authors. It's the second edition, and this is the updated version. Chapter 12, continuing on with pharmacology, the medication administration. All right. Remember that medications can be very life saving, and a lot of times we have to use medications in the field, but they could be devastating too. And we're talking about medication errors and stuff like that. We have to know what indications, contraindications of a drug, and we have to interpret. We will be talking about interpreting drug orders. We'll be talking about the advantage, disadvantage of certain routes of medications, and we're going to talk about proper techniques and equipment in this chapter. Uh, you must be able to calculate drug dosages, select correct medications, prepare medications, and adhere to principle of safe administration. And I will say about drug calculations, um, we will have a separate slideshow for that. So watch for it on my YouTube channel or my in-person class students. We will be going over that separately. Uh, Remember that the most common type of medication error resulting in death is the wrong dose. Maybe the right drug, but you gave the wrong dose. So, for example, epinephrine comes in two forms in our world. We have 1 to 1,000 or 1 to 10,000. 1 to 1,000 is 10 times stronger than the 1 to 10,000, and we use 1 to 10,000 IV. But what if you mix them up and give 1 to 10 or 1 to 1,000 IV? So they're getting 10 times the amount of epinephrine they need. So that could result in a death. So we have to be very careful. So how do we avoid this? It's knowledge of anatomy, physiology, pathophysiology, and pharmacology. We also have to have good skills in history taking, assessment, clinical reasoning. So we have to know what kind of medications our patients on. Maybe they're allergic to certain drugs, and we want to avoid giving them that drug or that classification. So this requires good assessment skills. When can drug errors occur, or places or phases that the drug administration in which the errors can occur? It's given an order or drug order, transcribing that order when we actually administer the drug by either the dosage or the wrong route, uh, patient monitoring and documentation, right? So we have to do the ethical thing, even if we know a drug error happened. We have to report that. We talk about the six rights of medication. It's the right patient. I know in out in the EMS world, out in the emergency field, you're usually dealing with one patient, especially for given medications. It's one patient. Uh, we say the right patient, however, because as an advanced provider, the hospitals are now opening up to letting us work in there. So you may have several patients. So you want to make sure you have the right patient. You want to make sure again that it's the right medication, the right dose, or given it the right way, the right route. Certain drugs cannot be given certain ways. For example, dextrose 50 or D50 can only be intravenous. If we give it IM, it's very necrotic. Or so we have to make sure it's only intravenous. Uh, it's the right time, which means this is like when we're doing like repeat dosage or um, we should be giving the drug now. How do we give the drug over what amount of time? Some drugs are rapid IV push, some are over like 10 minutes. So we have to use the right time. And then we're going to do the right documentation. We're going to document, right? Additional safety, medication safeties, the packaging, the labeling, the storing, the dispensing, and the administering. These are all additional medication safety considerations. Routes of drug administration. The intro route is usually PO or through the mouth. It goes through the digestive tract. It can be a liquid, solid, or semi-solid. The parietal routes is like it bypasses the gastric tract. So this is going to be like IV, IO, IM, sub Q. These routes don't require the digestive tract, right? So it's going to bypass it. Uh, uh, let's see. Parietal routes are inhalation, sublingual, subcutaneous, intermuscle, intravenous, bolus, or infusion. Now, the difference is a bolus is like a one time push, when a bolus doesn't push at all, or an infusion is like a drip, or um, if we're given like saline, bolus, or an infusion, and enterosity administration or through the IO. Talk about the routes. PO is oral, sublingual is SL, which is under your tongue. Drugs like nitro, subcutaneous or sub-Q is injected into the subcutaneous tissue. It depends on your region, but most in my area have done away with the sub-Q. We give it IM now, or intramuscular, which is a needle injected up to 5 ml of fluids into the skeletal muscle, or intravenous. It's right into the vein. It can be inhaled or inhalation, or it can be enterosity. Time to onset of action of the parietal administration drugs depends on the length of time that the medication enters. So, what this means is, like, for example, subcutaneous routes that's in that fatty layer is going to be the slowest onset. It's going to take longer to absorb through all that and get into the bloodstream. And it depends on how well the peripheral perfusion is. So, if we have something like, for example, shock, or something that's causing uh, the peripheral perfusion not to be adequate, then your absorption rate is going to be slower. Intermuscle is exactly what it says. We're injecting right into the muscle, the skeletal muscle. Intravenous or IV drugs, they're liquids that are injected or infused directly into the venous system. We have a tubing filled with saline or saline lock, or we could have it connected to a bag of IV, which would be the infusion, and usually has a rapid onset because we're delivering it right into the bloodstream. Interosis route, or the IO, is placed in the medullary cavity of the bone, medullary cavity of the bone, and it has rapid onset too. Uh, Drugs for inhalation can be gases, aerosol liquids or powders, like, for example, albuterol, absorb quickly across the respiratory membrane, the mucal membranes of the oral and nasal pharyngeal, or actually the lung tissue itself. Drug orders. An advanced EMT may only administer drugs on the order of a licensed physician, providing EMS medical direction. So what's that mean? Well, we have different ways of doing it. We have standing orders, which are your protocols. So those still orders are standing orders, right? And this is how we work a lot of the time. Written orders. Your book goes into to explain that this is more of the ALS or the advanced EMTs working in like an ER. But what they don't say in the book too much is, like, when we take IFTs or interfacility transfers, sometimes we get a written order for certain medications, especially like pain meds, and they'll be written out. Or you can have verbal orders. These are the ones when we call medical control on either the radio or the phone, and they give us orders for medication. You're always going to report these orders back to the physician word for word to verify that you understood this dose. And if it's wrong, we're going to address that by asking them, "Are you sure you want me to give this?" You know, blah blah blah, and then and you're going to document that. You're going to document how you carried out the order, any complications, and the patient's response to the medication. What are your ethical obligations? What are you ethically obligated to do regarding regulating drug orders, regarding drug orders, right? So if it's the wrong order, like we talked about, or the wrong drug, or it's not beneficial for your patient, it's your right. You need to stand up for that patient. And in the same way, if you make a medication error, we need to report this. Um, we don't hide it in the fear that we're going to get in trouble, because if we don't tell the uh, ongoing care, like the nurse or the doctor, they may give a drug and not know it, and then could interact with that. So we have to, ethically, we have to report that. Uh, Interpreting drug order, we're going to complete drug order information. We're going to do the drug name, the concentration if available. We'll get the drug dosage, the route, and the rate or frequency of repetition. If so, we're going to repeat. So when we get a drug order, especially like a written order, it'll have a drug name. Like, for example, it'll say morphine sulfate or morphine. Uh, it may not say the concentration, because concentrations differ between like hospital to hospital, ambulance to ambulance. So it may not have the concentration. They will give you the dose. Excuse me. It'll say like 2 milligrams, and then it'll say the route IV. Um, Q. And a lot of times it'll say Q, which means every 2 hours, right? Um, and your protocols will do the same thing, your standing orders. Remember that there is a standard abbreviations used. This is so we can avoid confusion or errors. Uh, Place leading zeros before your dosage, right? So anything that's a point dosage, like for example, nitroglycerin or nitro, it's 0.4. If you got a point and then a number before it, or a point before a number, you want to put a zero so there's no error. Because if you just point four, for example, it may be misunderstood, and then someone give 4 milligrams of nitro, which is 100 times the dose, or 10 times the dose of what they should be getting. Um, Drug dosage calculations, like I said, I'm not going to go into great detail in this section. I will have a separate slide section or videos that we go over drug calculation. So it is a mathematical operation requiring converting drug orders to units. Drug dosages are always in metric units. Metric is a base 10 system used in the science of medication. Uh, Prefix used for multiple and submultiples. Whole numbers placed to the left of a decimal. Fractions represented by placing value to the right of the decimal. So, for example, if it's like a quarter, it would be 0.25. So that's how we use fractions. Here's some common terms. Weights or mass is going to be grams. And then we look at micrograms, which is 1/1000th of a gram. I'm sorry, 1/1 millionth. And then milligrams is 1/1000th. Then we go on the other side. A kilogram is 1,000 grams. And so on for liters. We talk about milliliters. And when we're talking about meters, it's millimeters or centimeters. Like I said, we'll go into more detail on this in the next section. We're got to translate the orders to units to administer, basic calculations to find amount of drug when given physician's order, concentrate available. Use fractions to compare information you know. So we're going to solve by multiplying and dividing using x to the unknown. Like I said, I'm just touching on this, but we're going to go into great detail in another section or another video. Weight-based drugs, again, you have to figure out their weight in kilograms. So to convert a patient's weight from pounds to kilograms, you divide their pounds by 2.2. Just know that EMS personnel are pretty horrible at actually guessing a weight. So we're going to ask our patients about this. So we want to get a correct weight. When we're doing transfers, we can get the weight from the paperwork from the hospital or asking the nurse, because they always weigh the patients on their bed. So we need to do that. And for like children or pediatric patients, we can use the length-based tape, which used to be called Broslow, but now we call it length-based tape. That'll give us an estimation on their weight, or close. Again, the IV drip rate calculation we're going to go over in another section, but I'm going to hit it briefly here. We're going to use a formula that indicates drip factor of the tubing. A drip factor is your drop factor. So when we're talking about tubing, we'll talk about it more in depth in our next video. But most of our ambulance will carry like a 10 drop or 15 drop, and then those are called macro. And then we have micro drop tubing, which is 60 drop tubing. Certain medications you have to have a micro drop or 60 drop tubing to administer, like the dopamine or something like that, a levofed, stuff like that. So we'll talk about that in the next video, of course. Here's a nice picture of it. TKO is to keep open. KVO, keep vein open. That's usually about 30 ml an hour. Convert to pounds, kilograms. Well, like I said, we're going to talk about drug calculations. We're going to make it a separate slide. Setting the drip rate, we're going to adjust the flow rate to calculate the number of drops. So if the best way to do this is to figure out how many drops we need in a minute, divide that by 4, and then we time it for 15 seconds and see if we get that drip rate. So, for example, if we know we have, we'll just do something easy, 60 drops a minute, that means we're going to have 1 each second. So we're going to make sure we divide it by 4 to be 15. So in 15 seconds, we should have 15 drops. And if we have to, we can adjust the roller clamp, which is going to regulate to increase or decrease this flow. And sometimes some companies have pumps. A lot of times we go on transfers, you'll have a pump, but in infusion pumps you use to calculate and adjust the rate for you. Before we give any medication, we're going to perform a history assessment, right? So that way we can indicate if the medicine is indicated or not indicated or contraindicated. We're going to ask about medications that the patient is currently taking, their allergies, and the condition that the contraindication of a particular drug, conditions that could indicate a particular drug. We're going to get a complete baseline set of vitals. We're going to document all the procedures, reassess the patient, and document all our findings, and ask the patient if he's experienced a change in symptoms for which the medication was given, or if we got any new symptoms. Aseptic technique. This is how we prepare an area. If we're going to like do an IM or sub-Q or an IV, we're going to use an isopropyl alcohol wipe or iodine. We're going to identify the puncture site. We're going to swab and circular motion. We're going to clean this. Once it is disinfected, we're not going to touch it again. We're going to let that skin dry completely. And we're not going to let any equipment to be contaminated. Here's a big picture of it. Anytime we're doing any type of medication administration, we're going to use standard precaution. Never recap a contaminated needle. We're just going to get rid of it in the sharps container. And we're going to avoid doing any type of procedures in a moving ambulance if possible. Oral medications. So what is the most common in an oral medication that an EMT or an AEMT is going to give? And of course, that's aspirin. Sublingual, this is where we put underneath the tongue. The most common one then, again, is going to be nitro, of course. Nebulized medication or beta-2 agonist and anti-chlorogenic liquids that are nebulized. That means they're turned into like a mist or a fog by the compressed air or the dual neb, inhaled in droplets in contact with the respiratory membrane. This is like a dual neb setup. You're going to assemble all your equipment needed for procedure. You're going to select and check the medication. You're going to assemble the nebulizer by connecting the mouthpiece to the T connector at the top. Unscrew the cap, pour the medication in. Replace the cap. We'll hook it to our oxygen or portable at a rate of 6 to 8. We're going to instruct the patient to place the mouthpiece in the mouth, breathe in the medication, breathe in and out, and then we're going to reassess them, right? This is the meter dosed inhalers. If the patient has one, they're going to be more familiar with it. So we may need their help with their instructions. Nitrous oxide is an analgesic gas, which is used for pain, 50-50 mixed with oxygen. It alters the effect of the drug is to alter the mental status. Equipment used for injection, we're going to use gloves, alcohol prep, a syringe in the proper size with proper granulations or markings for measuring, the needle or filter straw, small gauze and small adhesive bandage, and then the drug in either a vial, an ampule, or pre-filled, and a sharp disposal container. Here's the different parts of the syringe. You have the needle adapter on the end right here. Then you have the barrel, which holds the liquid or the medication. And then you have the plunger. And when it comes to the needle, you have the hilt, which attaches to the needle adapter. Then you got the shaft, and then the bubble, which actually penetrates the skin. Drawing medications from an ampule, you're going to hold the ampule upright, gently flick it to move all the fluid to the bottom of the chamber. We're going to grasp it with like a piece of gauze or alcohol swab, and then we're going to gently snap off the ampule. We're going to make sure we don't spill the medication, or we're going to avoid getting cut by the glass. Draw the medication from the ampule, and just remember you're going to have to use a filter needle for this, and you can't use a filter needle to inject. So you're going to draw it out, dispense or get rid of your filter needle by putting it in the sharps container, and then we'll put the actual injection needle on to make the injection. If we're going to use a needle, or if we're going to inject it. If we're going to use an IV, we'll just hook it up to the IV. Drawing medication from the vial. Okay. Inject a volume of air equal to or greater than what we're going to draw. So if we're going to do like 2 mLs, we're going to pull the plunger back to 2 mLs or a little farther. We're going to insert the needle into the vial, and then we're going to squeeze the plunger. And this is going to put air in the vial, and then we're going to draw the desired amount. It's going to help us suck it right out into the syringe. Subcutaneous injection. A good example we used to do is epi or epinephrine, 1 to 1,000 during an anaphylactic shock or an allergic reaction. Granted, some protocols may still use this. I know most of them in my area is with the IM instead. But you're going to fold the skin between the thumb and the forefinger. We're going to inject the subcutaneous tissue at a 45-degree angle. We can only inject 1 ml. That's our maximum volume, subcutaneous. We're going to use a 25 gauge needle that's a 1/2 inch to 3/4 inch long. Yep. This is a picture of different sites, like the upper arms, like the abdomen or the upper thighs are good sites for subcutaneous injection. All right, so the subcutaneous injection, we're going to assemble all the equipment needed, right? You're going to need a needle, you're going to need the drugs, you're going to need alcohol wipe, you're going to need a syringe and a Band-Aid. And if you're going to use an ampule like here, you're going to need one of these filter needles here so it filters out any shards of glass that would be in there. Just no difference between a filter needle. They're usually blunt, but there is a needle called a blunt, which isn't a filter needle. So make sure it just says filter needle on this package. And then you're going to need, this is a 25 gauge injection needle. You're going to verify you have the right medication, right? And it's not out of date or it's not expired. We're going to draw up the medication in the syringe. We're going to disinfect the skin, pinch a fold of skin and position the needle at a 45-degree angle. Insert the needle into the skin and inject the medication. After we withdraw the needle, we're going to place an adhesive bandage over the injection site. Of course, we're going to get rid of the needle in a sharps container, and we're going to reassess our patient. Now, talking about intermuscular, to two drugs that we mainly use for intramuscular: epinephrine 1 to 10,000 and glucagon when we can't get IV access. It'll be a 21 or 23 gauge needle, 3/4 to an inch and a half in depth. We will insert it at a 90-degree angle. The injection sites are going to be the deltoid, which we can use a 1 milliliter maximum volume. The thigh, which we can use up to 2 milliliters of maximum volume, or in a glutox or the buttocks is 5 ml is our maximum volume. Sites for intermuscle, this is the gluteus, or the buttock, not the buttocks, but the gluteus. Here's the upper thigh and the deltoid. Intermuscular, we're going to assemble our equipment. Again, you're going to need the medication. You're going to need a syringe. You're going to need an injection needle, one properly for the IM. You'll need an alcohol prep and a Band-Aid. Again, we're going to select and verify the medication is the right medication and it's not out of date or expired. We're going to inject the air like earlier. If we're going to just slightly more than what we're going to draw out, and then we're going to withdraw the medication into the needle. The syringe. We'll prep the site by disinfecting it with the alcohol prep. We'll stabilize the skin over the site and place the needle at a 90-degree angle to the skin. We'll insert the needle and inject the medication. Before we inject the medication, we're going to draw back the syringe slightly. If we see blood or aspired blood, if we do aspirate blood, we're not going to inject the medications or remove the needle from the skin and start over at a different site. If we get blood, that means we're in the vascular system, and these drugs are usually stronger concentrations because they're got to be absorbed through the muscle. So they could be lethal doses if we get it right into the vascular system. And then after drawing the needle, we're going to drawing out the needle. We're going to dispose of the needle right away, and then we're going to put a bandage over the site, and then again reassess the patient. Auto injectors, they're packaged for rapid and easy administration. This would be the EpiPen or the twin inject auto injectors or the duodote, just like those. We do the 6 rights, of course. Verify the medication is not expired. Remove the safety caps. Grasp the body of the auto injector firmly. Position its hip to the lateral aspect of the thigh. Apply pressure until the device activates. Hold for 10 seconds. Remove the device and properly dispose of it, and document it. And, of course, reassess. Intravenous injections. They can be like Destruct solution, Narcan, lots of other drugs administered via intravenous line or saline lock. It's the rate of administration. Some are very fast, rapid push. Some are a slow push over so many minutes. Needleless system or syringe with needles. Okay. So to do an IV injection, right? You're going to already have your IV placed, and you're going to need your medication, and you're going to need something to disinfect. Again, verify the medication is the right medication. It's not expired. It's not discolored. It's good to go. You're going to prepare your syringe and whatever style you need. We're going to clean the IV injection port with alcohol. So like the saline lock or this is actually on tubing, like they're given an IV bolus. So they pinch it off and they're going to clean the injection port. Attach the syringe to the injection port, crimp the IV tubing above the site. Inject the medication at the proper rate. Discard the syringe in a sharps container. We're going to flush the IV tubing and readjust the drip rate. And then, of course, we're going to reassess our patient. So how are we going to start an IV? So a peripheral intravenous access for patient whom fluid administration or means for giving emergency medications. This is obtained by using a catheter that surrounds a hollow needle. You're going to follow your protocols regarding selection of fluids. Here's the parts of an IV needle, right? You have the flashback chamber, you got the hub, the Teflon catheter, which is the actual catheter, and then inside the catheter is your stylet or your actual needle. Equipment for establishing IV, you're going to need gloves for standard precaution. You're going to need a venous constricting band or the tourniquet. Now don't confuse this with tourniquet for bleed control. This is just a rubber band. You're going to need alcohol or iodine swab, saline lock or a saline flush, or an IV bag and IV tubing, catheter over the needle IV access device, small gauze, commercial IV dressing, adhesive tape, antibiotic ointment, and a tincture of benzoin. Catheter size. Needle is one size smaller than a catheter. Can be as small as a 24 gauge, which would be 3/4 inches long, or large as a 14 gauge. Usually we use 20 gauges and 18 gauges that are 1.25 inches. This is suitable for IV access in adults. 16 gauge or 14 are for rapid infusion, where we got to get a lot of fluids in really quick. 22 and 24 gauge are for patients who have extremely small diameter or fragile veins or children. Setting up the IV fluid and tubing, we're going to check the IV bag for the name of the fluid, make sure it's not expired. We're going to inspect it for damage or leaks. We're going to observe the fluid for clarity, color, visible component contaminants. We're going to open the IV tubing package and ensure the roller clamp is turned off. Remove the seal from the IV port in the bag. Remove the cover from the IV tubing spike. Insert the spike into the bag portion by twisting motion. Close the roller clamp. We're going to squeeze the clear drip chamber until it fills 1/3 to 1/2. We're going to open the roller clamp. This will flush the tubing out. This will remove all the air. And then we're going to place the tubing where it's accessible as we're preparing for the venal puncture. Selecting the suitable vein, the back of the hand and forearm, the AC or the antecubital fossa of the anterior elbow. We call that the AC. You have lower extremities you can look at, and at the very, very last resort, we get the external jugular vein. We'll put on the tourniquet to restrict the venous return and engorge the vein. We'll palpate the vein. We'll choose a visible vein when possible. If we can see it, that's better. But it's also a good idea to be able to fill the vein. The vein size specific to need. So if we don't need to get a lot of fluid in real quick or rapid push of drugs, we can go with a smaller vein. But if we're going to need to get a lot of fluid in or need a larger IV catheter, we're going to have to go with larger veins. Here's some sites for peripheral vein. Okay, so to actually start the IV or performing the venal puncture, we're going to disinfect the site. We're going to hold the IV needle at a 45-degree angle or less to the skin, the bevel up. I usually go about 22.5, somewhere in there. We're going to line up the direction of the needle with the direction of the vein and puncture. Once blood is visible in a flash chamber, we have flash or we got flash. You're going to lower the angle of the needle almost to where it's flush with the skin. And then we're going to advance that needle and catheter about 1 to 2 millimeters further. We're going to go a little further, but not much. And then we're going to push the catheter over the needle until the hub of the IV catheter is in contact with the skin. Never pull the catheter back over the needle. This will actually cut the uh, catheter, and we could get shards of that into the vein, so we don't want to do that. We'll release the tourniquet, apply pressure to the end of the catheter with one finger. This will occlude it, right? Keeping a finger on the vein to occlude it, we'll connect the IV tubing to the catheter and adjust their flow, and then we'll secure the IV with like our tegaderm and tape or what other method you use in your area. So we're going to prepare all the equipment for the beginning. You're going to need all this stuff. You're going to need the fluid, the bag, uh, the J-loop. This is called a J-loop with the saline lock on it. You'll need an IV, a flush. This is your tourniquet or your tegaderm, your disinfectant wipe, and this is your tourniquet. We're just going back over this. We're going to make sure fluid is clear and not expired. We'll spike the bag. We'll insert the spike of the IV tubing into the fluid bag, squeeze in the chamber, and we want it to fill up a third to halfway. We'll open the roller clamp, get all the air out, apply the tourniquet, disinfect the site. Once we found a vein, we'll disinfect that site. Stabilize the skin, holding the IV device, bevel up, no higher than a 45-degree angle. Insert the tip into the vein, advance it until we see a flash in the chamber. Once flash occurs, we advance the device 1 millimeter. This is milliliter, but it's millimeter, or 2 millimeters further. Stop, and then we're going to push the catheter over the needle until the hub makes contact with the skin, like she's got there. We'll release the tourniquet or the constricting band. We'll occlude the vein above the catheter, withdraw the needle, and discard it in the sharps container. We'll connect the IV tubing to the hub, wipe any blood from the site with gauze. Flash tubing, check the site for infiltration, and we're going to adjust the flow to the desired need. And then we'll use a commercial dressing to protect the site and secure the tubing. This is the tegaderm. So unsuccessful IV attempts and discontinued IV therapy. An unsuccessful attempt may occur because the vein is moved, the needles went too deep, the catheter hit a valve or meets resistance from a valve, or the angle of insertion was wrong. If IV discontinued after tubing connected, close the roller clamp or the clamp slide, or clamp the saline lock to prevent leakage. Remove the IV catheter needle combination and dispose it. Bandage the insertion. So what if we have to change a bag, an IV bag? We're going to change the bag with it when it has a few ml left. We're going to close the roller clamp. We're going to spike a new bag. We're going to fill that chamber back up to 1 to 3 or 1/3 to 1/2 full, and then we'll readjust our flow. Some complications we can see with IV therapy, always, it's a pathway to introduce pathogens, so we can get infections. We can have infiltration, which means we could, the vein could rupture and then get into the interstitial space. Air or catheter embolism. We can have bruising or hematomas. We could create blood clots. Phlebitis. This is when the vein gets inflamed. Progenic reaction. This is a sudden onset of fever, chills, or headache, nausea, vomiting from being exposed to foreign proteins. Or we could have fluid overload. IO or interosity access. We can do this in pediatric patients when their IV is difficult. We can do it in adult patients who need it as well. We can't get an IV for some reason, so we can go IO. We can use the proximal tibia. We can use the deltoid or the humeral head. And they are now teaching the distal femur head, the distal femur. We can use things like the ETIO or the big bone injection gun, or a new one on the market called the SAMS. or you can do a manual access. Here's the Easy Out device, the drill, and the 3 different needles, the different sizes. So, and they show them here. The yellow is for bariatric, the blue is the standard, and pink is pediatric, or the red is pediatric. This is the manual interosity needle, um, called the Illinois bone needle. Contraindications for using IOs: fracture of the extremity, if we've attempted in that same bone, if we got osteogenesis imperfecta, osteoporosis, or infection over insertion site. So some of the complications for IO attempts could be incorrect placement, obstruction of the needle. We could fracture the bone. It could get infected. It could have compartment syndrome, and they could create a fat embolus. We're going to assemble our equipment. We're going to set up a line and pre-filled extension. So you're going to need your drill or your IO source. Like this is the Easy IO, the Easy IO needle. You're going to need the J loop. You're going to need some saline. I think this is some lidocaine to numb it. And this is your tubing. We're going to find the improper site, 2 fingers below the tibial tuberosity. And we're going to go to the anterior medial surface. So we're going to go 2 fingers down from more than the bottom of the knee, and then we're going to go inside or move medial 2 fingers. We're going to use the right needle for the right patient. Pair the site with an iodine swab, and most of your IO kits will have the iodine swab in it. Place the needle on the driver. Never place a hand underneath or behind the insertion point. Fold a towel for support if need be. You're going to hold the driver at a 90-degree angle to the leg and drill the needle into the bone. So you'll push it through the skin until you fill the bone, and then you'll hit the drill and then you'll drill it into the bone. We'll remove the stylet or the guide from the needle. We'll attach the pre-filled or the flush. Sorry. We're going to observe the free flow of fluid and the absence of infiltration in the soft tissue. We're actually going to withdraw back a little bit or aspirate a little bit, and you can see if we got blood, bone marrow as well. Insert the IV bag into the pressure infused device. Inflate the infused bag. Follow your protocols. Secure needle and tubing with whatever how your company secures it. I know that Easy IOs have a stabilizer kit that comes with it. So, chapter summary. This has been a big one. So, we're going to administer medication comes from tremendous responsibility for patient safety. Follow safety principles using the 6 rights of medication. Using antiseptic techniques to reduce the potential for complications, especially infection. Know your equipment and how to troubleshoot it. Carefully calculate and verify drug usage. Select proper routes of administration. Administer medication at the right time and right rate. I'm going to document details on your medication administration. All right, that'll do it for chapter 12. And like I said, there will be a separate video on drug calculations, so you can find that here on my website or on the YouTube channel. And if you're in class, we'll do it actually in class. So until next time, this is Jim.